in Sri Lanka in future. So that is going to be on the medicines that we use to treat tuberculosis, which is one of the severe health risks that we have in the country. So, having said that, I will start the lecture. To keep the bandwidth, I will switch off my video and proceed with the slides only. So if you have any questions, you can put in the chat box, or at the end of the lecture, can ask the questions from me. And right, so let's start the lecture. Right, so as with any lecture, this is also going to have the learning outcomes or the objectives that you need to achieve at the end of the lecture. So the objective that you need to achieve at this 1 hour period, after the 1 hour period, is that you should be able to review the first line anti-tuberculosis medicines that you would have heard about it and you'd have seen in the wards. And also you should be able to discuss the common treatment regimes that we use in the treatment of tuberculosis. You should be able to review the side effects on the basic management of these, mainly the first line anti-tuberculosis medicines. And with regards to the treatment of tuberculosis in special populations, that is pregnant ladies, the breastfeeding mothers, children, those with liver disease, renal disease, you should be able to learn from this lecture. And at the end of the lecture, you should be able to have some briefly explain what we call the drug resistance, which is something that is coming up in the treatment of tuberculosis. And also there is a group of medicines that we call the second line anti-tuberculosis medicines. And you need to be able to have a brief understanding about these. So at the end of this 1 hour, if you can today mainly is how we are going to treat tuberculosis. So keep in mind this lecture will be very important and will be very, like, it will be something that you need to keep in your mind for the rest of your life if you are treating patients in Sri Lanka. Right. So you will learn about tuberculosis in the time to come. So what we try to achieve by treating tuberculosis in the first place is that we have to treat the patients who are having the tuberculosis. And we want to prevent the death from tuberculosis and also want to prevent any complications that come with tuberculosis. And we also want to treat patients so that they will not get a relapse of tuberculosis. As you know, pathology, or you very well know that there is latent TB or the post-primary tuberculosis. So we want to prevent that. And tuberculosis is an infectious disease. Therefore, by treating, we want to prevent the spread of the disease within the community. And by treating tuberculosis, we also want to make sure that this the thing called the drug resistance that is emerging with tuberculosis has to be prevented. So these are the main aims that we try to achieve by treating a patient with tuberculosis. Right. So the way that we try to treat tuberculosis is by using a short course of chemotherapy. That means that we use a chemical for a short duration, like in the case of tuberculosis, mainly for about 6 months duration. So when we want to treat somebody with this chemotherapy that we use to treat tuberculosis, there are certain things that we need to achieve. The first thing is we need to have medicines, the correct combination of medicines, which is of a good quality, that will cure the disease. And also we need to be able to prescribe these medicines at the correct doses according to the patient's weight and the patient's other parameters like their renal function. And we have to ensure the prescribed medicine will be taken by the patients regularly, and that patient will continue this treatment for that exact period that is prescribed. So those are the key elements that we need to achieve to provide the proper chemotherapy for tuberculosis treatment. Right. So if you look at the basis of the chemotherapy strategy that we use currently in the treatment of tuberculosis, it is mainly of two main theories. The first theory is we want to prevent resistance or the drug resistance that is developing for tuberculous bacillus. So to do this, the theory behind this is, yeah, can you hear? Is there any problem?
We can hear, sir.
Right. Was there any problem? I heard someone making a noise.
No, sir.
Right. Okay. Okay. So to proceed with now, the drug resistance simply means that the medicine, the organism is virulent and it will not, respond to the medicine that we all are giving. So if you look at, the cavity of tuberculosis, which is of 2 centimeters in size, and it is said that it will have over 100 million of bacilli. Now, if you look at these bacilli, and if you look at the resistance patterns in the world, we find that like the presence of isonisate resistance will be seen in about 1 in a million of these bacilli, whereas the rifampicin resistance will be about 1 in 100 million. So based on these frequencies, we also know that if one bacillus is resistant to isonisate, usually that bacilli will be responding to rifampicin. And also the vice versa. If something is resistant to rifampicin, that will be, the isoniazid will be working on that particular bacilli. So we don't see, rarely we see this cross reaction where bacilli will be, resistant to both that organism. So the chemotherapy strategy that we use with combination therapies in the treatment of tuberculosis, what we try to achieve is that, if we combine two medicines, that the amount of bacilli that we would have resistance would be reduced to 1 in about 10 to the power 14, which is a very negligible amount. So this is one of the key strategies that we are trying to achieve with the chemotherapy in the treatment of tuberculosis. This is one strategy. The other basis is that the tuberculous bacillus, it has different, it works at different places, and there are different populations of TB bacilli. And by using different medicines, we try to attack the bacilli that is there in different positions. So if you look at the diagram, so there are a lot of TB bacilli which are in the extracellular region, which is rapidly multiplying. So that will be affected by the lot of medicines that we use in the treatment, which we will come across in the slides to come. And then there are some of these extracellular bacilli which are semi-dormant, that they do not multiply fastly, but they will be multiplying at the intermediate stage. So some of the medicines will act on them. And then there are some of these intracellular bacilli. So there will be TB bacilli inside macrophages. So some of the medicines will act on them and make sure that the bacilli will be is dead. So likewise, by using different combinations of medicines, we try to attack these different subpopulations of TB bacilli. So the basis of chemotherapy is to attack these different bacilli as well as to prevent the resistance from developing. So when a patient presents to us with tuberculosis, and when we want to treat a patient with tuberculosis, so there are different considerations that we have to do prior to planning out the regime that we would try to adapt for that particular patient. First thing we would have to consider would be, we have to consider whether this patient is presenting to us with tuberculosis as a new patient, or is it the first time that we detecting that the patients have tuberculosis, or is it someone who had been having tuberculosis treatment but is coming with failure of the treatment. So that is important in deciding the regime that we are going to adapt. The other important matter is, where is the disease? Is it in the lung, or is it in the extrapulmonary organs? Is it in the meninges? Is it in the central nervous system? Likewise, we have to consider which part of the body is affected from the disease, because the duration of treatment, sometimes the combinations of therapies that we use are different at different places. The other important factor to consider is other comorbidities. As you go along the lecture, you will realize that most of the TB medicines, they have hepatotoxicity. Some of them have hematological side effects. So we have to consider the patient's current status before we choose the treatment that we are going to give to the patients. One other important aspect that we must check in all patients with TB is their HIV status or the retroviral status, because TB itself is an AIDS-defining illness. So therefore, we have to consider this because it has implications on the management of these patients. And again, since the drug resistance to tuberculosis is something emerging, so when a patient presents with TB, we have to dig into the history to find whether there is a past history of tuberculosis, and sometimes also the country of origin. There are some countries which has high prevalence of these treatment-resistant tuberculosis variants. Once we have taken a patient, once we have chosen the patient, and when we have chosen the sort of the course of illness that we are going to treat, so what we try to do, the principles that we try to achieve in the treatment is, first we would determine their retroviral status, and all patients with TB must be checked for their HIV status, and if it's positive or negative, there can be changes in the management. You will learn them as we go on. Once we choose to treat patients, we have to make sure that we are going to choose the safest and the most effective therapy, which can be given for the shortest period of time. And wherever possible, we try to use multiple drugs which the organisms will be susceptible to. And we will not use single, only one medicine, because to prevent the development of resistance. We have to ensure that the patients are adherent to the therapies. And in the treatment of tuberculosis, there is one strategy that we use, which we call the directly observed therapy short course. We call it the DOTS or DOTS, or we sometimes call it the directly observed therapy, which stands to DOT. So DOT simply means that you make sure that the patient is swallowing the tablet in front of you, so that the compliance is 100% ensured. So as people, there are a lot of people that are eligible to be in this program. So the people who can provide this DOT strategy in the treatment of TB are, as healthcare workers, we can provide the facilities. And also some field healthcare workers like the midwives, PHIs, they can provide the facility. Sometimes the general practitioners can. Some of the healthcare workers in private health facilities can. And some trained community volunteers, they can come and help with the strategy. Sometimes the community leaders or any person in the community who can be trained, it may be some of the relative of the patient, can be used in the DOT strategy, so that we make sure that the patient is taking the tablet completely. Having that background on the strategies that we use to treat tuberculosis, so this is going to be the basic, the most important part of the lecture. So if you are going to not forget all what I'm going to tell before and forget what I'm going to tell in the future, but make sure that you listen to the next few minutes to understand about these 4 medicines. So this is going to be the core of the lecture that you are going to learn today. So anti-tuberculosis medicines, they are mainly 2 categories mainly. We call the commonly used ones as the first line, so that we try to use in the first instance, and failing which we go to another line of medicines which we call the second line. So the first line medicines are isoniazid, which is referred as H, rifampicin, which is referred as R, ethambutol, which is referred as E, and the pyrazinamide, which is referred as Z. So these medicines in Sri Lanka are mainly reserved for the treatment of tuberculosis to prevent the resistance, because we do have a high prevalence of tuberculosis in the country. So we are going to look at each of these medicines one by one. So this is going to be the core of the lecture. So make sure that you learn your maximum from this part. Let's start from so before going into the initial, the first line medicines, let's just look at some of the second line medicines. So you will learn these things when you have the IPD module. So there are the quinolones or the fluoroquinolones like ciprofloxacin, levofloxacin, which are one of the second line medicines. And then you have the aminoglycosides. So streptomycin is one of the commonest ones that we use in the treatment of tuberculosis. And also we have the amikacin and capreomycin, so they can be used sometimes. And then there are other antibacterial agents like ethionamide or cycloserine and profesimine, which is also used in the treatment of leprosy. So these are some of the second line medicines that are available. So our lecture is going to be focused on the first line medicines of tuberculosis treatment. Right. So when we treat patients with tuberculosis, there are 2 main phases in the treatment. So the first one is called the intensive phase. So the target of the intensive phase is that is when you are going to hit the patients harder. So there is a high population of bacteria. So we are going to give so many variety of antibacterial agents so that they will go and attack the bacilli at several locations in the body, and they will rapidly kill the bacilli. And by doing so, what they are going to do is they will prevent the emergence of any drug-resistant mutants. And also, by clearing the bacilli from the circulation, from the system, so they will also make sure in the intensive phase that the infectivity of this the bacilli from one person will be reduced by using the intensive phase. So in the intensive phase, you use 4 medicines. And then there will be the continuation phase. So that is when we have killed the bacilli, we have hit them hard, we have reduced the population of the bacilli, and therefore the infectivity of the person will be less. But as I told in the previous picture, since there are bacilli at different locations in the body, so we have to make sure that we continually give the chemotherapy to make sure that all these dormant bacilli at different parts of the body are attacked by the chemotherapy regime that we are going to use. So when we, in our standard treatment for a patient with pulmonary tuberculosis, so we do have an intensive phase of 2 months, and then after that we have continuation phase of 4 months, and altogether we have 6 months. So in the standard tuberculosis regime, so how is this intensive and the continuity phase is arranged is that all the 4 first-line medicines that I informed, the isoniazid, rifampicin, ethambutol, and the pyrazinamide will be given for 2 months in the intensive phase. And after that, in the continuation phase, we will be continuing with isoniazid and rifampicin. So isoniazid and rifampicin will rapidly kill the dividing TB. And the pyrazinamide is the antibacterial that will go into the acidic environment, particularly in the cavities and in the macrophages, and they will make sure that those organisms will be dealt with. And ethambutol is something that we use to prevent the resistance. So that is also one agent that we use to prevent the emergence of resistance. So after all 4 agents have been used, in the continuation phase, you will continue isoniazid and rifampicin. So they will kill whatever the bacilli that is remaining in the body, and that will also sterilize the fibrotic areas that are developed in the body. So this is for pulmonary tuberculosis. But in the case of, if you are treating tuberculosis in the central nervous system, so then we might replace ethambutol with streptomycin, because the ethambutol, the ability of ethambutol to cross the blood-brain barrier is minimal. So now we'll go to study the first line anti-TB medicines. So the first one that we are going to start with the H, or the isoniazid. We also call it INAH. So INAH or isoniazid acts on the mycobacteria, and it will inhibit the synthesis of the mycolic acid, which is important for the bacterial cell wall. And this isoniazid has the ability to freely pass through to the mammalian cell wall. So therefore, they can affect the intracellular organisms also. And they are bactericidal for the organisms which are rapidly multiplying. I hope you know these meanings in the F2 module. So they can kill the bacteria that is rapidly multiplying. And for the bacteria that is not rapidly multiplying, sort of in dormant state, so they will be bacteriostatic and then prevent it from developing further. And with regards to the pharmacokinetics of isoniazid, so isoniazid is given orally, it will be well absorbed, and it will be distributed throughout the body, including the CSF, so it crosses the blood-brain barrier. And also it has the ability to penetrate into the caseous tuberculous lesions that we have at several parts of the body. And it is metabolized by the liver by acetylation. So there are 2 groups of people, some of them called the slow acetylators. So the metabolism of INAH will be low in the patients with slow acetylators. Therefore, the action of isoniazid in that group will be prolonged. So they have a TR of about 3 hours. But there is a group of people who are rapid acetylators, so they will rapidly metabolize INAH. Therefore, the effect in that group of that population will be reduced compared to the slow acetylators. So this is excreted unchanged in urine, and partly the acetylated, so mainly as unchanged, but partly as acetylated forms as well. So Of the common side effects of isoniazid, apart from the GI and other side effects, they can have sort of skin eruptions and allergic skin rashes. Sometimes they can be life-threatening as well, going into form of Stevens-Johnson syndrome even. But what are more important to note are there are some side effects which may not be the commonest, but will cause serious side effects for the patients. So the most important ones that you need to remember, as I think, are in red. So isoniazid is a hepatotoxic, so it can damage the liver. It can cause a neuropathy, so the patients will feel lower limb numbness and hand numbness. So this is mainly to be due to the pyridoxine deficiency. So pyridoxine is an enzyme that is involved in the metabolism of a lot of carbohydrates, proteins in the body. So isoniazid will sort of compete with pyridoxine and cause a pyridoxine deficiency at the tissue level. So you will manifest as a neuropathy. This is commonly seen in patients who are malnourished. And another side effect that you should not forget is that hemolytic anemia, which can happen in patients with the G6PD deficiency. Sorry for the spelling mistake. So there will be G6PD deficiency that will cause an hemolytic anemia. And there are other side effects, like they can have optic neuritis, they can cause toxic psychosis, and sometimes seizures. And if you have heard, there is a disease called systemic lupus erythematosus. So some of the medicines can mimic that symptoms, that syndrome. So INH is one of them, and also they can have pellagra due to vitamin deficiency. Word about hepatotoxicity with INH. So the hepatotoxicity of INH, it's not very common. The percentage is less than 1%. And the incidence is increasing when the patients are older. And usually this doesn't happen over, first or second day after the commencement of the treatment. So it happens weeks after. So once the hepatotoxicity sets in, so if you withhold the treatment, it can revert back. So sometimes then you can try to reintroduce at a later stage, and sometimes you might be able to continue it at the second stage. So it's not something that if you developed hepatotoxicity once, you can't give it again. But unless it was a very serious hepatotoxicity, if it was just a mild transaminitis, of course you can continue the INH again in the subsequent attacks. So the medicine interactions of INH is that there are two enzymes that you need to remember of the anti-TB treatments. One is inhibiting the metabolic enzymes in the liver, which is isoniazid. So it will inhibit the metabolism of medicines like phenytoin, carbamazepine, methotrexate. So what happens is that the metabolism of these medicines will be reduced. As a result, the circulating levels of the medicines will be increased, and therefore the risk of toxicity will be higher when you are giving medicines in combination with isoniazid. Contraindication. So if there is a severe hypersensitivity to isoniazid, it's contraindicated. If you had an anaphylaxis also, if you had an acute hepatitis, then you will not use because of the hepatitis toxicity. If there is a serious hepatotoxicity with isoniazid, you will not use it. But if it's a transient one, you can try to restart it in the treatment. And cautions for patients with epilepsy, because I told you it can increase the seizures, and patients with alcohol dependence, you can have problems, and diabetic patients, there can be problems with neuropathy, acute porphyrias, and retroviral infection have problems. It are cautions for isoniazid. Because at multiple levels it can affect. So one of them is that the diabetes, HIV infection, all this can result in sort of peripheral neuropathy as well, so that you might not be able to differentiate between isoniazid and these other causes. Right. So as trainee doctors, one important part that you need to remember is when you are prescribing medicines to patients, you need to advise them on the use of them. So with regards to the anti-tuberculosis treatments, like particularly concerning isoniazid, so when you are advising patients, you need to advise first regarding the tuberculosis, that if you take the treatment for 6 months, then of course you can have a cure. Therefore, you have to motivate them to adhere to the therapy for the full course of treatment for the prescribed period. And then, of course, you have introduced the directly observed therapy to the patients, and also advise the patients to undergo family screening. And then the other advices specific for isoniazid is that if you are eating red fish like shipjack and tuna or the balea, what happens is that you can have a reaction with the headache and sort of feeling funny, lightheadedness, and itching and flushing. So all this happens due to the release of histamine, which is there in abundance in these fish. So there is an enzyme called histaminase, which is going to metabolize histamine and inhibit these side effects. But what happens is isoniazid is going to inhibit the histaminase. So when the histaminase is inhibited, your histamine levels will be high, and you will have all these feelings when you are taking the said fish. Therefore, we advise patients on anti-TB treatment to avoid particularly fish like balea, which we commonly use. And also, with anti-TB treatment, we always ask them to stop alcohol because it interferes with them at several levels, sometimes with the absorption of the medicine, sometimes with the hepatotoxicity, sometimes with the neuropathy it is developing, sometimes with other metabolic pathways. So because of all this, we advise all the patients to stop alcohol while taking anti-TB treatment. That's about the first medicine, which is the isoniazid. So going to the second one, which is rifampicin. So rifampicin, the mechanism of action is different. So it's going to inhibit the DNA-dependent RNA polymerase in the prokaryotic cells, which is the bacteria, but it will not affect the eukaryotes like the human beings. And rifampicin will enter the phagocytes, and they can kill the intracellular bacilli as well. And other than the use in tuberculosis, we also use rifampicin when we want to treat other mycobacterial illnesses like leprosy. And also rifampicin is an antibiotic which has sort of a wider spectrum. So it has gram-positive cover and gram-negative cover. So therefore, in certain instances, we use it for other scenarios as well. Like in the case of meningitis, we sometimes use it as prophylaxis. So the pharmacokinetics, it's given orally, so therefore it's well absorbed from the gut. But if you have food, sometimes it can have interfere with food. And it's also widely distributed, and it goes to the CSF, and it's well penetrated to the CSF, and you can achieve the same, you can achieve good levels there. And the thing about rifampicin is, it is known to go into all the body fluids, and they will cause an orange colored tinge in the body fluids, like in the urine, tears. So the patients might get worried about this. So therefore, it's something that we need to advise the patients on the possibility of discoloration of the body fluids. And it's also metabolized by the liver. So one thing about rifampicin is that rifampicin is a medicine that is going to induce the hepatic enzymes, whereas isoniazid, it inhibited. So therefore, the drug levels increased. But in the case of rifampicin, it is going to induce the hepatic enzymes. So therefore, the metabolism of the medicines will be increased when the enzymes are induced, and then the actual concentration of the medicines in the body can be reduced. So rifampicin can self-induce its metabolism. So therefore, when you give rifampicin for a longer period, its half-life can reduce from 3.4 hours to the shorter period when the patient is on rifampicin for a long time. And it's mainly excreted in the intrahepatic circulation and partly excreted in urine as well. So the common side effects of rifampicin is you have to advise all patients on the discoloration of their body fluids. It can happen anywhere. It can even happen the discoloration of their skin, sweat, tear, and all that. You can have the gastrointestinal side effects like nausea, vomiting, anorexia, arthralgia, myalgia, lightheadedness. So these are common symptoms. The rare and the more serious ones that we need to remember are the hepatotoxicity. Just like INH, rifampicin is also a hepatotoxic medicine. It can also cause flu-like syndrome. It can have cutaneous reactions with flushing, pruritus, and a rash. Sometimes rifampicin can cause an hemolytic anemia that can be very severe, will lead to a renal failure, and even result in respiratory shock syndrome. There is another side effect of rifampicin that we have to remember in mind is thrombocytopenia that can manifest with bleeding with purpura. So these are rare, but these are the potential dangerous side effects. The hepatotoxicity The hemolytic anemia, thrombocytopenia with purpura are the more deadly ones. So, just like all other medicines, if there is a history of hypersensitivity to rifampicin, it's contraindicated. And for someone with jaundice or history of severe liver disease, that will be contraindicated. Another important thing is that if a patient with retroviral infection is on treatment with a protease inhibitor, so use of rifampicin will be contraindicated in that scenario because rifampicin is going to reduce the effectivity of protease inhibitor in the treatment of HIV, resulting in treatment failures in retroviral treatment. So in that scenario, it will be a contraindication. And rifampicin is cautious in alcohol use, porphyria, liver dysfunctions, as well as in the renal impairment, because part of it is excreted in the kidneys. Right, this I told you about. So rifampicin is going to induce the hepatic enzymes. So therefore, that is going to increase the metabolism of medicines. So it affects rifampicin itself, but also it affects other medicines metabolized by the liver enzymes, like the warfarin, tolbutamide, diazepam. So all these medicines, the blood levels will be reduced when the patient is given with concomitantly with rifampicin. And another failure that will happen is there can be a failure of oral contraceptives, which is also metabolized in the liver. Therefore, when you combine rifampicin with oral contraceptive pills, the efficacy of the oral contraceptive pills can be reduced. So this has to be warned to patients who are on this form of contraception. And the other corticosteroids in the body will be also metabolized in the liver. So rifampicin will also induce that metabolism. So therefore, there will be a deficiency of corticosteroids to the body, which will manifest as Addison's disease. So that can manifest as Addisonian crisis. So, and if you combine rifampicin with other medicines which are also hepatotoxic, so you are giving two medicines that are hepatotoxic together, so that can worsen the hepatotoxicity. And as I told in the very beginning, so antacids, sometimes food can also reduce the absorption of rifampicin from the gut. So advising patients, so again, general advices, and you have to advise that you have to take it about 30 minutes after meals just to avoid the absorption failures. But if the patient has a lot of GI symptoms, you can ask them to take with the meal so that the symptoms will be reduced. You have to ask them to avoid taking alcohol and reiterate the side effect of where their body fluids can become orange in color, so that they will not be worried. And sometimes the patient is wearing a contact lens. Sometimes the contact lens can be permanently stained, so that has to be informed to them. And if the patient is also on treatment with the protease inhibitor for retroviral infection, so you have to inform them that that is contraindicated at that point. And when the patient is on treatment with rifampicin, we do liver function test initially in about 3 days and about in 1 week's time, like that, and gradually prolonging the interval between the testing. So we have to advise the patients to attend and do the full liver profiles, as well as the full blood counts, to detect these hemolysis and the other thrombocytopenias, which can be deadly for the patients. So this is about the second medicine, the rifampicin. So next one on the cards will be the pyrazinamide. So pyrazinamide, it is acting in a different way. So it's going to, so there is an enzyme called the pyrazinamidase, which is going to convert the pyrazinamide into its active metabolite, which is the pyrazonic acid. And the pyrazonic acid, that is the active metabolite, is going to inhibit the fatty acid synthesis in the mycobacteria, so thereby prevent its other metabolic pathways. So generally, the pyrazinamide is inactive in the neutral pH, but when there is an acidic pH, the pyrazinamide works as an tuberculostatic, so that will prevent the sort of the multiplication of the bacilli. It will not kill as such. It is going to prevent the multiplication. So since it's active in the pH, acidic pH, so when the mycobacteria is in the body, so the mycobacteria will be phagocytes by the phagocytes or the macrophages, and thereby will form something called the phagolysosome. You all know how these are formed. So when the phagolysosome is formed, there will be an acidic pH in that environment. So therefore, the pyrazinamide will act very well at the level of the phagolysosome, particularly in the intercellular organisms. So given orally and is well absorbed orally, also well distributed, and it crosses the blood-brain barrier very well. It reaches the same concentration as that of the plasma. That's a very good point of pyrazinamide. And it's metabolized in the liver. T-half is about 9 to 10 hours, and is excreted mainly through the kidneys through glomerular filtration. These are about the pharmacokinetics. Side effects. So again, the GI side effects can be there. You can also have skin side effects with photosensitivity and flushing of the skin. Other than that, there can be rare but important side effects like the hepatotoxicity, again with pyrazinamide as well, and also you can have the hyperuricemia as well. So if you look at all the first-line anti-TB medicines, pyrazinamide is considered the most hepatotoxic medicine of the first-line anti-TB medicine. So when we give this to patients, so somebody with liver disease, pyrazinamide is the one that we try to introduce last as well because of its high hepatotoxicity. It can also cause an hyperuricemia. Then you can have something called gout. If you have not learned about gout, you will in the time to come. This can also worsen the other the vitamin deficiencies manifesting as pellagra, and can also cause a sideroblastic anemia. Contraindications in severe hepatic dysfunction, if there is a history of hypersensitivity, and if there had been a history of acute gout or acute porphyria, it's contraindicated. And caution in renal impairment because it's excreted renally, and if there is gout, it's cautious. And if the patients have diabetes mellitus, again, pyrazinamide is a caution. So how will you advise patients? You give the general advices, and then you advise the patients that if the patient is developing fever, there is yellow discoloration of the eyes, if there is tenderness over the right hypochondrial region, and if there is associated severe loss of appetite or anorexia, so that may be an indication of liver injury. So therefore, you ask the patients to come quickly if those symptoms are there. So like with other anti-TB medicines, so you advise them to avoid taking alcohol while they are on pyrazinamide as well. You have to monitor patients' blood sugar levels because your blood sugar control can be sort of bad when the patient is of pyrazinamide because they can cause an hyperglycemia. So that's one of the reasons why diabetes is becoming a caution in the case of pyrazinamide. So we've learned about isoniazid, rifampicin, and the pyrazinamide. And let me go to the fourth medicine or the last first-line medicine, which is the ethambutol. So ethambutol is exclusively used in the treatment of tuberculosis. So it will be taken up by the bacterial cells, and this will also inhibit the bacterial cell wall synthesis. So ethambutol will become bacteriostatic once the first 24 hours of its use have been passed. And with pharmacokinetics, given orally, well absorbed, distribution is good, but the problem with the ability to have high concentrations in the CSF or crossing the blood-brain barrier is minimal compared to other first-line agents. But this is mainly in the healthy meninges, whereas if there is inflammation with tuberculosis, then you can achieve therapeutic concentrations if there is TB meningitis. So ethambutol is also taken up by erythrocytes and then will be slowly released. So that is the reason why we use it to prevent this resistant formation and sometimes acts on these dormant forms. So it is partly metabolized by the liver with a T-half of 3 to 4 hours, and it's excreted by the kidneys. So the important side effect to remember from ethambutol is the optic neuritis. So this is the patients will have sometimes will manifest from blurred vision or sometimes from the impairment of the color blindness, and then will gradually progress to a blindness, complete blindness. So generally this is said to be dose related, and if you detect it early, that you can reverse it. So if you detect it and stop ethambutol early, so that you can reverse it. So that's one of the key things. So if the patient is on ethambutol, if there is slightest eye-related symptoms, that we have to make sure that we screen this patient properly, quickly, and take necessary actions. Other than the optic neuritis, it can also cause gouty arthritis, cause an abdominal pain, can cause gastrointestinal side effects like nausea, vomiting, can have peripheral neuritis, liver toxicity, as well as myocarditis. But the one to remember will be the optic neuritis. So, as expected, it's contraindicated if there is a history of optic neuritis, and it's contraindicated for small children under 5 years. One main reason being they will not be able to explain to you about all these visual symptoms, because the monitoring is mainly guided by symptoms. So if the patient is not complaining, so you might not be able to detect it early. And if the child's eyes are affected, so then the child will be blind for the rest of their lives. And if there is renal impairment, that is also a contraindication because it's excluded renally, only in severe renal impairment cases. Cautious in elderly patients as well as young children because of the risk of optic neuritis. The risk is more in children. So medicine interactions, it's self-explanatory. So if you are giving any other medicine along with the neurotoxic medicine, if you give ethambutol along with another neurotoxic medicine, so the risk of neurotoxicity can be higher. And also if you give aluminum containing antacids, then that will also reduce the absorption of ethambutol when given orally. Patient advices, you give the general advices, and then you will tell them if there are any visual symptoms like blurred vision or eye pain, red eye, color blindness, any loss of vision, you have to stop the medicine and immediately seek a necessary advice. So these are about the 4 main medicines. This is the core of the lecture. So if you have learned this part, so that is the only thing that I want you to achieve today, to learn about isoniazid, rifampicin, ethambutol, and pyrazinamide. So just to touch on some of the other medicines that we use, streptomycin is, well, it's also in the first line sort of medicines. Also, sometimes it's used as a second line medicine. So anyway, streptomycin is an aminoglycoside. It's a group of antibiotics, which you will learn in the IPD module. It will inhibit the protein synthesis and works as bactericidal antibiotic. And this is not absorbed by the GIT, so therefore it's given intramuscularly as an IM injection. And the CSF penetration is poor, but when it is inflamed, it can reach the level. So therefore, you use this as a treatment in the case of TB meningitis. And as with all aminoglycosides, they are excreted renally. And the adverse effects of streptomycin, it's the common effects of the group of aminoglycosides. So you will have ototoxicity manifesting as tinnitus and hearing impairment. You will have vestibular toxicity, you will have dizziness and vertigo, and then it will also have a nephrotoxicity affecting the kidneys. So we use streptomycin, as I told, in the treatment of TB meningitis. Sometimes if the patient is very ill with tuberculosis, you might have to use streptomycin. And if the patient is having multi-drug resistant instances, you might use it. And if it's not responding to the conventional treatment, we might have to use streptomycin. Just to touch on the other ones, the same slide that I have used before. So the second line anti-TB treatments, so we have learned about streptomycin as one of them. So other medicines of that particular group of aminoglycosides are the amikacin, capreomycin, and kanamycin, so they can be used. And if the initial treatment fails, and then there are different fluoroquinolones like the ciprofloxacin, levofloxacin, and moxifloxacin. So they are second line anti-TB treatment. And then there are the other sort of antibiotics like ethionamide and cycloserine and clofazimine and the PAs, para-amino salicylic acid. So all these can be used as second line. You don't want to know all this, but you will learn about the fluoroquinolones and the aminoglycosides in the antibiotic lectures in the modules to come. Right. So you have been listening to me running through a very fast lecture. So I want to give you all about 2 to 3 minutes break. So in the meantime, there is a Zoom poll which you can answer, and after that we'll proceed with the lectures. Can you all see the poll? Can you see the?
Yes.
You can see, no?
Yes, sir.
Can you hear? Can you see it? Or?
We can see it, sir.
Right. Okay. You can answer it and take about 2 to 3 minutes to answer it, and then we'll proceed with the next part. So HRZD means H stands for isoniazid, R for rifampicin, Z for pyrocinamide, and E for ethambutol. Some of you are marking the sixth question also. There is no question in the sixth one. It's a mistake. So only the first 5.
No, sir, we have to answer all to press submit. I suppose that's why.
Right. Okay. Sorry. It's my mistake. Sorry. I see 23 people have answered, so there are 108. At least 50 must be listening now. So let's take another 1 minute and finish it off. Okay, I've given 3 minutes, so 30 seconds, and then I will start. Right, so these are easy questions, right? You won't get sort of these sort of advanced questions for your exams. These are too easy. Can you see the results? Can you see the results? Students, can you see the results?
Yes, sir.
Right, so you can see now which of the following will rapidly kill the tuberculosis bacilli. So mainly that is the first 2 medicines, the isoniazid and the rifampicin. They are the rapid killers, so they will kill. So most of you all got it correct, so that is good. Ethambutol, of course, is not. Pyrocinamide is mainly for intercellular, so semi-dormant ones. Which of the following best works against intracellular bacilli? So intracellular bacilli mainly best works are, well, it has to be pyrazinamide and the rifampicin. Isoniazid also has some intracellular action, but it's mainly rifampicin and the pyrazinamide. Ethambutol, no. Patient while on anti-TB treatment started complaining of lower limb numbness. What of the following is most likely cause? What do you think is the reason for this numbness? Someone?
So polyneuropathy?
Yes, so that's the polyneuropathy. So which of the medicines can give polyneuropathy? Polyneuritis or polyneuropathy?
Isoniazid.
Yeah, so it's isoniazid. So we give, to prevent that, we are giving pyridoxine. When we give isoniazid, along with that, we also give the pyridoxine to the patients. Right? So we give 10 milligrams of pyridoxine along with it. So this is how the questions come. You have to apply your knowledge. We will not ask which of the medicines cause neuropathy. So you have to work the things out. Okay. While on anti-TB treatment, the patient developed blurring of vision. Obviously, this is the easiest of all the questions. And unfortunately, others have got some of that wrong as well. So that's bad. It's a temporary. While on anti-TB treatment, the patient had flushing, tachycardia, sweating at a sea party. What are we talking about? What do we talk about in this question?
Rifampicin.
Why do we talk about rifampicin? What is the theory? For which medicine did I tell that there is a release of the inhibition of histaminases when you have, when you take certain fish? Yeah, you will have a lot of histamine. So histaminase is necessary to the breakdown of histamine. So isoniazid is going to compete with that. So then, of course, you will get this flushing sort of reaction. So this is the sort of question you will ask. So you will have to apply your knowledge. We will not ask which is going to affect with Balamalu and all that. So tea party and all this you need to consider. Right, okay. That was just a small lecture break. I hope that was good for you all. So let's proceed with the rest of the lecture about it. So to summarize what I have been telling so far, isoniazid is the potent drug that will kill the with an early bactericidal activity, and they will prevent the emergence of drug resistance, and also will also have sort of less adverse drugs compared to the others. Rifampicin is a potent bactericidal and sterilizing drug. It has both extracellular and intercellular actions, but mainly extracellular. Semi-dormant bacilli will be affected and will prevent the multiplication of those bacilli. Pyrazinamide is bactericidal and sterilizing, so it's mainly on the intercellular semi-dormant bacilli, which are multiplying in an acidic environment and will reduce the relapse rate. Ethambutol is mainly bacteriostatic, and it will help in preventing the emergence of resistance for other medicines. Right, so now we have learned about the 4 key medicines. So now we are going to treat about some of the special conditions with regard to the treatment of tuberculosis. And of course, streptomycin is a bactericidal antibiotic. Right. So all these graphs that I'm going to show you are available from the National Program for Tuberculosis and Chest Disease Control. So I will also put the certain book. There is a publication from them that I'll put to the LMS. You can refer that, and I ask you all to read it. It's a big book, so there may be elements that are too much for you all, but it's very interesting and very easy to read. So if you look at all the key medicines, you leave streptomycin out, isoniazid, rifampicin, pyrazinamide, ethambutol. So early bactericidal activity will be there in isoniazid and rifampicin mainly. And sterilizing is mainly with rifampicin as well as pyrazinamide, and prevention of emergence of resistance mainly from isoniazid and rifampicin as well as coming from ethambutol. That's the main reason why we combine this treatment with ethambutol to prevent the resistance. And I told you there is intensive phase and a continuous phase. So patients, the newly diagnosed patients for the first time, pulmonary or extrapulmonary tuberculosis. Extrapulmonary is in the, so maybe in the gut or other organs. So you will have an intensive phase of 2 months of isoniazid, rifampicin, pyrazinamide, ethambutol, and then there will be 4 months of continuation with isoniazid and rifampicin. But then there are treated cases. So the patients who have been treated, and some can come with the relapse, and some can come with the failure after treatment, and some can come with who have been lost to follow-up. So all these things have definitions which you will be introduced to. Otherwise, if you read this book that I'm going to share, you can learn all this. So these groups, there are different phases. So for them, the intensive phase is 3 months of isoniazid, rifampicin, pyrazinamide, ethambutol, and then there will be a continuation of 8 months. And sometimes you will add streptomycin into the intensive phase in some of these scenarios. Right. So we learned about the medicines, but when we treat tuberculosis, we do not use different tablets of isoniazid or different tablets of rifampicin. So we have developed things called the fixed dose combinations or the FDCs. So fixed dose combination is a formulation with 2 or more ingredients, and they are combined to a single dose so that the patients can take 1 tablet instead of taking 2 tablets. That will improve the compliance of the patients. And this is used in the treatment of tuberculosis as well as the treatment of AIDS as well as malaria. So the advantages of using a fixed dose combination is that we know that when you are giving sort of the medicine separately, then you will have to adjust them for their weight because these are given per weight dosage. So then you can have some errors while you calculate all these dosages and take it. So if you have combined preparations, if you have prescribed numbers of tablets for certain kilograms of weight, then the chances of messing up that will be minimized. And the other is that patients would like to take 1 tablet instead of taking 4 tablets. So the hypothesis is that the patients will have better compliance with fixed dose combinations. And say even if the treatment is not now in TB treatment, we have the directly observed therapy. So even if we do not observe the patient, so the patients will not have a choice of selecting. Say if you have RGs and CRs at home, you know there are tablets, some of the tablets that they like to swallow, and some of the tablets they do not like to swallow. They'll take only the tablets that they like to swallow. So if you give all 4 different tablets in different preparations, so then they might take some of them which they can tolerate, and some with a lot of gastric side effects they might not tolerate. Therefore, you will not have this combination therapy. So therefore, if you give a fixed dose, it's a single tablet, so you don't have a choice of choosing which one you want to take, even which one you don't want. Single tablet, you have to take it. And when you are giving all 4 together, you ensure that all the 4 tablets are given through a single, all the 4 medicines are given through a single tablet. So therefore, you can have the prevention of the resistance. Disadvantages are like when you are giving all 4 are in the same tablets, all 4 medicines are. So therefore, when you are giving, if you mess up 1 tablet, so you will be overdosing 4 medicines. And so there can be toxicity of 4 medicines. And the other one is like, we might think when we give fixed dose combinations, the directly observed therapy is not necessary because it's 1 tablet and everybody will swallow it. And we might assume that, and the dose strategy might not be well implemented. And the other thing is, if you use poor quality fixed drug combinations, what happens is then you will not have adequate concentrations of medicines in the body, and then you will have treatment failures. And when we are using FDCs, we can't monitor for the toxicity of different medicines. Therefore, it will be very difficult for us to monitor for side effects. Right, so there are different combinations. FDC2 is combination with rifampicin and isoniazid. FDC3 is combination of rifampicin, isoniazid as well as ethambutol. FDC4 is combination of rifampicin, isoniazid, ethambutol, and pyrazinamide. So you don't want to know all these milligrams of all in the FDCs. Just know that there are different tablets with different combinations that we use in the treatment of tuberculosis. And this is how we prescribe it according to the weight. So we weigh the patient, and if the patient is 55 kilos, and if the patient is in the intensive phase of a new patient, so then we give 4 tablets daily for 2 months, and continuous phase is 4 tablets daily for 4 months of the FDC2 tablet. Here you get the FDC4 tablet in the intensive phase, continuous phase FDC2 tablet, right? So likewise, there are different tablets, and we use different like number of tablets for their age, and that's how we are going to use it in the treatment. Right, so the TB medicine treatment, it's obvious, it's 6 months, 2 months of intensive phase and 4 months of continuation phase. But this changes, this is mainly for pulmonary tuberculosis, but if it involves bone disease, so it involves renal TB, CNS tuberculosis, then you have different regimes. It ranges from 9 months to 12 months based on the area that it is affected. And along with the first-line anti-TB medicines, there is another group of medicines we sometimes use in the treatment of tuberculosis, that is the steroids. So by using steroids, we are going to reduce the organization and the fibrosis of the areas where the TB bacillus has affected. There is no proper consensus on the use of steroids, but in general, in certain conditions, we definitely are going to use it. That is TB meningitis. So that is the first indication for steroids. And if there is TB pericardial effusions, if you have genitourinary TB, if you have laryngeal TB with life-threatening airway obstruction, so after ENT opinion, we can use it. And even spinal TB, if there is evidence of cord compression due to spinal tuberculosis, your spinal cord is compressed, after neurosurgical opinion, you might use steroids. So these are some of the indications that we generally use steroids, but there are some cases where we take the decision individually, whether in pleural effusions, when you want to treat abdominal TB, when you want to treat TB lymphadenitis. You don't want to know all this. So if you know all four medicines and then there are some indications that we use steroids, that will be adequate as a third-day medical treatment. And tuberculosis itself can sometimes affect your adrenal gland, and that can cause some TB adrenalitis. So therefore, you will have less adrenal hormones, resulting hypoadrenalism. So in such scenario, of course, you will have Addison's disease. So therefore, you will use hydrocortisone replacement in that case scenarios. You are having Addison's disease due to tuberculosis. Then sometimes when you are treating tuberculosis in a patient with retroviral illness, when you are treating both the conditions, you get this syndrome called immune reconstitution inflammatory syndrome, or we call it IRIS. So if a patient is having IRIS also, there is a place of steroids in the treatment of TB. And when we discussed of rifampicin, I told that rifampicin is going to sort of induce the metabolism of steroids. So therefore, the activity of steroids will be less. So therefore, you can have a tendency to become hypoadrenalism when the patient is of rifampicin, because the patient's own steroids will be fastly metabolized. So if the patient is developing Addison, so hypoadrenalism due to the metabolism of the hormones, then you will need replacement with hydrocortisone. And generally for tuberculosis, in the treatment of tuberculosis per se, like in the case of TB meningitis or TB like pericarditis, we are going to use prednisolone. The doses you don't need to know. But in the case of other areas, like there is hypoadrenalism due to TB adrenalitis, or if there is some problem with rifampicin, so in such scenarios, we are going to use hydrocortisone replacement for those patients. Right. So we talked about the medicines, how we give the medicines, and about the use of steroids. So another thing that I told you in the very beginning of the lecture is one of the emerging problems in the treatment of tuberculosis is the development of resistance. So you need to know a little bit about resistance, not in great detail. So there are three types of resistance that a patient can develop. The first one is called the acquired resistance. That is, as the name says, if you are taking anti-TB treatment, say if you have been previously treated or if you have taken the treatment for more than 1 month, and if you have developed a resistance of tuberculosis, then that is called an acquired resistance. So which means when you culture the organism, when you do the culture and ABST, you see that most of the organisms are not responding to the medicine. So that is the resistance. And then there is primary resistance, where that happens in the patients who have not been treated before and who had had a course of, they may have had a course of anti-TB treatment, but for a period less than 1 month. So if one of these patients come with a population of microorganisms in the cultures, which is not responding with the treatment, the tested antibiotics, then we call it the primary resistance. Primary in the newer diagnosed ones, or those who have used for less than 1 month. Acquired in those who have been previously treated, and those who have used anti-TB for more than 1 month's time. And then there is something called the viral type resistance. So that is when you culture the organisms, most of the organisms will be sort of responding to the treatment, but there can be small populations of Mycobacterium tuberculosis where they do not show response to the antibacterial agents that we are testing. So this may be not purely due to the resistance to the medicines, because there are only a small population there. So that may be due to some of the spontaneous genetic mutations of that particular sort of viral, particular bacteria that is there in the culture medium. So we call it the viral type resistance. And there is another nomenclature, which is the more clinical nomenclature that you need to know, monoresistance. That is, if in a patient with tuberculosis, and if you have the bacilli are sort of resistant to one of the antituberculous medicines, we call it a monoresistance. And polyresistance, of course, if it's more than one of the first-line anti-TB medicines, but not isoniazid and rifampicin, because these two are the main agents that really kill the bacilli faster. So if the patients are resistant to both of these agents, isoniazid and rifampicin, both of them, we call them a separate name, which is called the multi-drug resistant TB. That is where the organism is resistant to both isoniazid and rifampicin, and along with that, they can have resistance to other line of medicines as well. There is another category called the extensively drug resistance TB, or XDR TB. So in that scenario, there is resistance to both rifampicin and isoniazid, as well as they are also resistant to any of the quinolones, the cipros, levofloxacins, and then also is also resistant to one of the second line injectable agents like amikacin, capreomycin that we might use. So you can see the extensively drug resistant ones are, of course, they are resistant to most of the most effective treatments of tuberculosis. There's something called rifampicin resistance. So at any of these, if even mono, even poly or multi-drug or extensive, in any of these categories, if the patient is resistant to rifampicin, then we call it rifampicin resistance. So it can include in any of these categories. Okay? So these are the types of resistance that we learn with regards to anti-TB treatment. So just about the four main medicines. So isoniazid, when the bacilli become resistant, so they will have reduced penetration into the bacteria. So important thing about resistance is there are very minimal cross-reactivity. So somebody cross-resistant. So like if somebody is resistant to isoniazid, but they will work for the other four. Something is resistant to rifampicin, but the other three agents will work on that. So like that, there is no cross-reactivity between these groups. And rifampicin, the resistance happens when there are chromosomal mutation changes that will target sites of the mycobacterial DNA dependent RNA polymerase enzyme will be inhibited. That's just the mechanism of action, and it can be changed during these mutations. And ethambutol, of course, if you use it alone, then can cause resistance, but when you combine it, very less likely. And pyrazinamide is the same. So if you do not combine all four together and give one alone, then there is high chance of developing resistance when you give pyrazinamide. But when you do combinations, that chance is reduced. Right. So now I think I passed 1 hour is also gone, and you have learned a lot about TB medicines as well. So there are some of the smaller topics which I will just touch upon. You will have the slides. You can go through these later on and then improve. So I know it's a lot of content, but I need to cover this to cover the objectives of the lecture. Right. So let me start it. So one of the main problems that we have with tuberculosis is hepatotoxicity. So it happens when the liver is affected, because most of these medicines are hepatotoxic, and usually patients can be asymptomatic, but there's a spectrum of diseases, and you can even go into a liver failure. So you define your hepatotoxicity if your AST level is above 5 times upper limit of the normal, or more than 3 times upper limit of normal with symptoms of jaundice and right hypochondrial pain, etc., etc. So the hepatotoxicity incidence will depend on your age and the pre-existing liver disease and other problems. And when a patient is having hepatotoxicity, what we do is, if the patient's AST is more than 5 times the upper limit of the normal, or if they have more than 3 times with associated jaundice, we are going to stop all the medicines. So in cases if the patient is very ill due to tuberculosis, that you can't stop all medicines, or in the case of like TB meningitis where you can't withhold treatment, not giving anything to the patients. So then you might combine other medicines like streptomycin, levofloxacin with ethambutol, which are not very hepatotoxic. But you're going to stop all the ones, mainly the rifampicin, isoniazid, and the pyrazinamide, which are the more hepatotoxic ones. And then you let the liver function settle. So you wait until then returns to normal value, or like slightly less than up to 2 times upper limit of the normal. And then you can actually reintroduce. So then, of course, you can't use the fixed dose combinations. You separately introduce isoniazid. So this is the order you go about. So you stop all the liver toxic ones, the isoniazid, rifampicin, and the pyrazinamide, and you try some other bridging therapy if necessary. And then the liver function is normalized. You give isoniazid first separately, not the fixed dose combinations. And then you monitor the liver functions for some time, 2-3 days, and you look at it and gradually increase the dose of isoniazid. So once it comes to its normal dose, and then if the liver function is okay, then you are going to give the second agent, which is the rifampicin. So then you try to, over 2-3 days, go to the necessary sort of the concentration or the milligram strength of the tablet. And then if that is also normal, then you are going to introduce the last one, which is the most liver toxic one, which is the pyrazinamide. So suppose when the patient is introduced to, and patient with isoniazid he was okay, and with rifampicin he was okay, and suddenly after pyrazinamide if he is developing sort of reactions, then of course you will need to stop the medicines and then use the not give pyrazinamide but use the other two combinations of medicine. So that's how we do when we are treating patients. Same with skin rash. So if the patient is having sort of a mild skin rash, you can try some antihistamines. But if there is a petechial rash with low platelets that we were worrying with rifampicin, whether there is thrombocytopenia with purpura, you have to look at the platelet count and if necessary, immediately withhold the medicines. If there is a severe skin rash involving all the mucocutaneous areas, you will obviously withhold all the medicines. And just like the other scenario, we will try to slowly introduce one by one. So this is the way that we do it. We start with isoniazid, then go to rifampicin, pyrazinamide, ethambutol, and streptomycin in that order. And then in the first day, second day, third day, like that, we try to gradually increase the doses. So this is what we do for a patient with skin rash. And sometimes there is something called the paradoxical reaction when you give TB treatment. So the patients will start to develop their, the lymph nodes will swell, and there can be discharges coming from it. So this is called paradoxical reaction. So this is seen about 1/5 of our patients. And what we do is we try to rule out drug-resistant TB from the cultures. We try to get an aspirate from the lymph node and look at it in detail. And we might use some steroids and NSAIDs if necessary. And when a patient with cirrhosis or liver disease becomes positive for tuberculosis, then of course there's a lot of strategy to go, but generally we will try to avoid the pyrazinamide, which is the main one that is dangerous, and we will try to use combinations of medicines which are safe or relatively less liver toxic. And for patients with renal disease, it's the same. So basically, most of these medicines can be given for patients with early renal disease, but someone who is under dialysis, you might need to change the medicines, and there are different strategies that we use. I will not go into detail, which you can refer to the resources that I'll be sharing with you all. And important things for patients who are pregnant. So tuberculosis is not an indication of termination of pregnancy. All the first-line anti-TB agents are safe in pregnancy, so they can be continued in pregnancy. Mainly isoniazid, rifampicin, and ethambutol. But for pyrazinamide, there is limited data on its teratogenic effect, but it's recommended by WHO to continue. And the second-line agents like fluoroquinolones and the aminoglycosides are generally contraindicated in pregnancy. And one thing to remember is if you give a pregnant lady with rifampicin, that will increase the postnatal hemorrhages in your child. So therefore, after the birth, the child should be given vitamin K supplementation to prevent that. And for someone who is breastfeeding, all these medicines are safe to be used in breastfeeding, the first-line medicines. So the concentrations in breast milk will be minimal. If some breastfeeding mother has become positive for TB, so then there is a whole protocol to go about it. But generally, you can breastfeed the child by wearing a mask. So there is a whole protocol with this scenario you can read in the book that I will share. And generally in breast milk it doesn't pass, so you can obviously give breastfeeding, but make sure the mother is taking the pyridoxine supplements while the patient is isoniazid, because there can be a lot of vitamin deficiencies coming up. Second line medicines, of course, there are some contraindications for breastfeeding, but for the first line, you're all right. TB in children, so children are also at high risk of tuberculosis, so they can have severe illness like meningitis and miliary TB. So we do use the same regimes that we use for adults, but the dose will be adjusted, and they do have separate combination therapies. So this is the combination therapy that we use in children. So based on their weight, they have rifampicin, isoniazid, and pyrazinamide, but ethambutol generally not used in patients less than 5 years because they can't complain of their ear symptoms. I told you about the risk of optic neuritis. So unless they are very severe ill due to tuberculosis, we might not use it. We might try to manage with the other two. So the intensive phase has 3 medicines mainly, and then the continuation phase has the rifampicin and isoniazid. But the combinations in these medicines will be, the concentrations will be reduced. Right, TB, HIV patients, so it's complex. You'll have to read about it. So usually TB can present as atypical cases and disseminated tuberculosis. So those who are having low CD4 cell counts, you will need isoniazid prophylaxis to prevent tuberculosis. And we know protease inhibitors will interact with rifampicin, and therefore there can be HIV treatment failures, and there can be risk of iris that I told you when you treat a patient with HIV treatment with anti-tuberculosis medicines. Right. So I don't think it's about just 5. Anyone has anything to ask? Anything? I know it's a heavy lecture, but generally is with this sort of a lecture. Anybody wants to ask anything? Like train went. Anyone wants to ask anything? Any unclarified area? So I will obviously put this to the LMS. You can sort of get it from there. Or if you have any questions, you can even email me and ask. And I will share some references that you need to refer to when you are learn about this. So some acknowledgements. I would like to acknowledge Vipula sir, because some of this content that on my slides are from his presentations. So I would like to acknowledge him for that. And also the references are, you need to refer the Rangandale and the Sri Lanka student formulary. Most of the content is based on that. And then there is the National Manual for Tuberculosis Control, which was published in 2016. I'll also put it into the LMS. So please refer it, read the core areas. That's very important. And thank you. So the last part of this is, you can sort of, there is a questionnaire. I think those who are here while you are preparing for the next lecture, please fill the questionnaire in the chat box. The link is in the chat. Okay. If you don't have any questions, I'll stop by now. So please fill the questionnaire and finish it off. If you have any questions, just ask.